Ruth, tell us, we kind of are referring to the potential for risk factors. So help our audience, like, what are the risk factors for developing HCC?
Yeah, so HCC can, so risk factors including like viral hepatitis, Hep C, hepatitis B infection, and alcoholic liver disease, and or NASH from the metabolic syndrome. I think all those can cause chronic inflammation, eventually lead to cirrhosis, which is increase the risk of having HCC develop in the liver.
That's very important. If anything, we just heard about like really the 4 key risk factors for which patients get HCC. Hepatitis B, which is a DNA virus, so it really is very non-foreign to our own DNA. The hepatitis C, which is an RNA virus. The heavy alcohol use and Lennox cirrhosis. And of course, the new oncomer that we're seeing more and more of, which is non-alcoholic steatohepatitis that leads to non-alcoholic fatty liver disease. Manish, are you seeing quite a bit of NASH nowadays?
We are, yeah, we are. And it's oftentimes sort of the diagnosis of exclusion, right?
Yeah.
You go through, you see the patient.
Yeah.
By the time they get to me, they already have HCC.
Yeah.
And you know, you go through, okay, no viral hepatitis, no heavy alcohol history. So you start narrowing it down and you discover that, okay, they probably are someone who fits this metabolic syndrome picture. They may be a diabetic, they may be obese, they may have hypertension and things like that. So that kind of fits. You know, oftentimes we don't necessarily have a biopsy of quote unquote healthy liver showing, showing the fat, right? But I think that, that's oftentimes a presumed diagnosis. And at the end of the day, in many ways, the way we treat the disease is not dependent on the underlying etiology. So it's oftentimes sort of an academic discussion of how did this come about.
That's interesting you bring this up. Actually, if anything, Amit, I would like to ask you, are we dealing with the same disease for a patient with Hep B versus Hep C versus alcohol, or is it like 4 different diseases?
Yeah, I think that Hep B is definitely a different disease. You're talking about a DNA virus that integrates, and so you can actually develop HCC in the absence of cirrhosis.
Without cirrhosis,
Exactly. So I think that we would all agree that hepatitis B is its own beast. I think that hepatitis C is also different than alcohol and non-alcoholic fatty liver disease. So I think when you take a look at this, it really breaks down into, at least in my mind, viral-mediated HCC and non-viral mediated HCC. I think alcohol and non-alcoholic fatty liver disease are 2 diseases that start in terms of fat accumulation by different means, but you end up on one pathway. So these 2 diseases are very similar.
I hear you. I hear you.
I'd like to comment.
Go ahead.
I'd like to bring up hemochromatosis. And I've seen several cases of hemochromatosis that have been treated with phlebotomy without cirrhosis and still get HCC.
Absolutely, they can.
Your comment?
I mean, hemochromatosis is, if you have hemochromatosis, you're at the highest risk of developing HCC among all risk factors. The issue is that just hemochromatosis, while it's one of the most common genetic diseases among Caucasians, is a relatively rarer cause compared to these other 4 that we just listed.
Totally agreed. If anything, in my comments at the end, I was about to say that the most 4 common, if we look at any practice, being ours or any of yours, and you look what kind of the common risk factors that you will see among your patients with HCC, they're going to be Hep C, they're going to be Hep B, they're going to be alcohol, and they're going to be the non-alcoholic fatty liver disease. That's really what we're seeing day to day. But you're right, there's many other risk factors that definitely can be brought up, among which, of course, hemochromatosis and many other that we don't necessarily will see any common reason. Question for you, Mark. Patient with HCC, would you read your treatment plan differently if they are Hep C versus Hep B? We're going to talk a little bit more about treatment later, but I'm just at least in the mindset. Would you say Hep B, then I'll think that way versus Hep C from the systemic therapy?
At this point, I don't think we have a definitive answer to that. I think there are some clinical trials that show that some patients with Hep C might respond better to one therapy over another one, and we can talk about that later in the treatment section. But I still think that those are sort of subset analyses of clinical trials, and we don't have any definitive proof right now.
Fair. So we still read it, at least for now, as one disease.
Ghassan, can I bring up one point that I think is important for all of us to consider is, there are new therapies for hepatitis C, or relatively new therapies for hepatitis C. So even when we talk about hepatitis C today, most of the HCC that's being developed is going to be in the setting of cured hepatitis C. So I think it's important for us to remember this in a couple of different ways, is that even when you cure hepatitis C, if these patients have cirrhosis, they remain at high risk. And so I think that if we don't continue to screen this population, we're going to see more and more advanced HCC present in this population. But I think it's an important subgroup of the hepatitis C that will be one of the main risk factors as we move forward.
No, I'm happy you bring it up. If anything, I was to conclude that at the end, at the moment, our current demographics in regard to the patients and what are the risk factors in HCC is evolving. And I would refer everybody to the excellent paper that was reported in JCO in 2016, in July 2016, that actually showed that the population that's doing extremely well in regard to the fact that there is already vaccination for hepatitis B is actually the Asian population in the US. Definitely there is a lower risk factor for HCC in that population.